I am privileged to have with us Professor Wagdy Talaat, the President of the Egyptian Society for Medical Education, as our keynote speaker about the community, a major partner in advancing health profession education. Please, if you have any questions, write them on the chat box and Dr. Wagdy will answer them live. Thank you very much. Over to you, Dr. Wagdy.
My name is Wagdy Talaat, an international FAIMER Institute global and core faculty. For over 15 years, I have been facilitating and teaching community-based education sessions in the International FAIMER Institute and its regional institutes around the world. With my FAIMER fellow colleagues, we have done multiple research work around community-based education and even published a whole book about our global experiences in community-oriented, community-based education. And it was a WHO publication that was published in 2014. Before I start talking about the role of the community as a major partner and contributor in health professions education, I would like to make a comparison first between community-oriented, community-based education, and then to highlight the role of the community in all of this. There is a lot of confusion between community-oriented and community-based education as two distinctive educational strategies. Let me do this sort of comparison between the two educational strategies at the level of the definition. So in the year 2000, Hamad defined community-oriented education, saying that it's a curriculum that takes into consideration in all aspects the priority health problems and community health needs of the country in which it's conveyed. Please notice here that community-oriented education is about curriculum. But in community-based education, we renewed actually in our publication in 2014 its definition as a form of experiential education about the facilitation of learning in, with, for, and from the community. So in community-based education, we are transforming here the whole education from being taught inside the medical school and in the clinical years. It's focused mainly on the tertiary care in the university or teaching hospital to a whole process of training within the community with early exposure since the year one, and the whole program actually in its major part, it's done outside the walls of the school. So this is the major difference between community-oriented and community-based education. Quite few schools are community-based education in the whole world, actually. Probably Al Jazeera in Sudan, where Hamad was working, and Suez Canal University in Egypt, where Wagdy Talaat, myself, was working, were the pioneering community-based education schools that were established in 1978. But as you see here, community-oriented education, when we talk about it, we should realize that all health professions education institutions in the world should be community-oriented by default, but not necessarily they should be community-based education because it's more sophisticated and it needs some special resources to implement this educational strategy. Then if we talk about involving the community either in community-oriented education or community-based education, it's again something that's not very simple, but it's really very sophisticated, because usually the community is having a traumatic experience about academia in general, because they used to go to the community for their own interest, just to do some research on the community, you know, taking history, taking some samples, and they disappear and they never go back to the community, either with the results of their investigations or with treatment to the ill patient in the community. So we have to be very careful if we decide to involve the community in our educational process, especially in community-based education. So from our experiences, our global experiences, and how to approach the community in health professions education, we found out that this should be done in certain phases. So if we begin with the first level, which is called community exposure and building trust, we have to be open to the whole community around our school, not just the community that's urban and just around the school, but also we have to go to the rural community, because our students, when they graduate, they will go to such places, and if they don't have an experience with the community in the different geographic situations, like in rural areas, they will face a big problem. And going to such communities, isolated and remote communities, it takes hardships to reach such communities. This picture was taken during our regular visits at Suez Canal University in Ismailia, Egypt, when we were regularly visiting the rural communities around us with our students and our faculty. And this picture is in Bangladesh, where the students, as you can see, are going to the rural community. It's not something easy, and you have to prepare and train your students how to approach such communities, because the community especially the rural community, needs special treatment and special training. As you can see here, the medical student in Bangladesh going for family visits, see how skeptical the little kids and their mother, and when they try to visit them for the first time, they have to earn their trust before even they try to approach such communities. Probably focusing a little bit on the attitude of the students. Every curriculum in the world, it should be in the form of the cognitive domain, the psychomotor domain, and the affective domain. Here comes the attitude, and you see how the student very early she tries to treat this elderly woman in a very humane and kind way. The same thing in South Africa, here dealing with handicap, and in Pakistan, when they treat the little kids in a very nice way so they can learn through serving the community. Then comes the second phase, which we call community diagnosis. And in this phase, the students sit with their tutors, with a large crowd of the community, with the informal leader who introduce the student and his tutor to the large crowd of the community to discuss together their health needs and expectations from having a medical school or health professions education school around them, that they can have some expectations and some relationship with this institution, and we will see how they can develop their relationship gradually from being very passive very early to being active later on, and we will see what we will have them involved with in the mature stages of relationship with the community. Here, the students are writing down the way the mother is dealing with her kid, how she gives him a bath, and how she takes care of the cleanliness of her baby, how she is dealing in general with the care of her baby. Here, other students in Pakistan too, they are taking history from a couple of community ladies. Here in Pakistan, while during the community-based learning activities, they see a health problem. Here, the sewage disposal problem, and they know that this can affect the general health of the community. So they have to reflect on that in their portfolios while going back to their school. At the third level, which we call community mobilization and empowerment, because if we need to develop our relationship with the community, we have to further develop their capabilities and skills in an empowerment way. To do that, we first have to do some little services to the communities, like measuring the blood pressure, and probably measuring the blood glucose level, and such very simple procedures. The community, they like that very much, but then we start to train selected members of the community, like the female health workers, how to do some injections, or to take some measures for their babies, and even sometimes they can do some weighing to their babies, and to do child growth curves. If this happens, then the community start to realize that they are in a different situation, having a community-based school around them that can meet sometimes their expectations. So they start really to participate actively in this process. The tutors train some community health workers, where whether female health workers or male health workers, like this, and this is in Bangladesh. This picture is in South Africa, where some community members have participated with, or donated even, a land to build up a very simple health post, where community health workers can receive community members for checkups in isolated areas, under supervision from the medical school. If we do all that, we will reach the most mature level of relationship with the community, which we call community university partnership, and sometimes we call it community university government partnership. It's a tripartite partnership, because we need the government very much to be involved in this partnership to facilitate so many things for the community when they start this very high level, where the community is measuring up to the level of the university and the local government, head to head. They are full partners now. They know exactly their own interest and how they can deal with that. So they fully participate with the health professions education institution within their area. They happily receive the students for training. They fully cooperate with the educational process. They even sometimes participate in evaluating the students and the students' projects. Even they attend the defense of these projects right in the school. community health, community informal leaders. They attend such student project defense in the school, and they participate in the assessment of the students themselves. If all this happens, we are reaching now a very mature stage between the community and the university, and this is a very stable stage where the transformation happens to the community, and within the university, the faculty and the students are also transformed. That leads to a sustainability of relationship between the community and the university. By this, we close the loop, and as you can see here, we started with level 1, or community exposure and building trust, to level 2, community diagnosis, then level 3, community mobilization and empowerment, then level 4, community participation, and from community participation, we jump to community university partnership. And from this very stable stage, we ensure the transformation and sustainability of our relationship with the community. We call this staircase of community involvement in community-oriented, community-based education. I explained that this is not a very simple process as some might think. It's a complex way of dealing with the community. We have to be very careful. We have to treat the community in a very humane way, and our students learn through serving the community. We have to provide some services to the community, and we have to respect the community members, and we have to teach our students this attitude part, how to deal with the community and how to respect the people who they are going to serve after their graduation. And thank you very much.
We do have some time for questions and answers, and Maha is going to proceed with asking Dr. Wagdy about the questions on the chat box. Over to you, Maha.
Okay, welcome everyone. Regarding the chat, we received several contributions from the participants. From Dr. Wolfers, we currently host about 500 multidisciplinary health profession students in about 50 rural sites. Each site hosts teams from the 6 programs we have in our College of Medicine. And we received a question from Dr. Yusra Mahmoud. She was asking if how frequently, in case students are exposed to rural communities, how frequently do they have to go there, and does it interfere with their schedule? Dr. Wagdy, would you like to answer that?
The question, and thank you everyone for listening, watching the presentation. Yes.
Over to you, Dr. Wagdy.
Can you hear me? Yeah.
Yes.
Shall we repeat the questions again?
We can.
No,
you are muted.
I heard the question. Am I? No, I'm not.
No, I can hear you, Professor.
Okay. Okay. Let me first thank you for listening, and thank you very much for watching the presentation. I would like to answer the first question about the duration of exposing very early our students to the community, whether at the level of the rural communities or even the urban communities, or at the secondary care level where we can receive the community as well in the Ministry of Health facilities, and even the tertiary care at the level of the teaching hospitals is considered part of community-based education. So all of this, we are working on a whole package, starting from exposing our students to the community proper at all levels where we can meet the community, whether at the rural or the urban, or at the level of the Ministry of Health facilities, whether these are district hospitals or the very sophisticated teaching hospitals, even the university hospital. The range of this exposure, it ranges from 10% of the whole education time till 50%. So we increase the dose gradually. At the first year, we expose our students with just 10%, like 1 day per week. They go to the rural and urban communities, but in the very late, the clinical years or the final years, we increase the dose up to 50% of their education time. I would like also to respond to a question about the role of the local government in all of this. Then we have to differentiate between the role of the government in the governmental health facilities, like the primary health care units, or at the level of the secondary care. All these belong to the Ministry of Health, where we receive the community as well. So when we send our students for training, we have to make a deal, a written deal with the local government up to the level of partnership with the government. So it's a tripartite partnership between the university, the community, and the local government. But at the level of exposing our students to the community proper, we try to avoid the formal leaders, because they are usually politicized. They belong to the government, so we prefer the informal leaders, because they are the key to the community outdoors, and they help us a lot to be able to communicate without problems with the community itself. About the articles, I can send you tons of articles about such experiences. We even, as I said before, we have a WHO publication that describes such experiences from different parts of the world, and it's done by the FAIMER fellows. Thank you, FAIMER.
Thank you very much, Dr. Wagdy, for this enlightening presentation.